Hi, everyone. So as Dr. Haas mentioned, I am one of the oncology fellows here at Penn. I have probably met a lot of you over the last couple years in Dr. Haas's clinic and Dr. Narayan's clinic. But today what I'm going to be talking about is some of the side effects of the treatments that we use for renal cell cancer, and specifically focusing a little bit on managing those toxicities. So the treatments for kidney cancer really fall into three categories that you've heard a little bit about over the course of this conference already. But those categories are the vascular endothelial growth factor tyrosine kinase inhibitors, or the VEGF TKIs for short, which are the oral pill-based therapies that we use. Then we have another category of immunotherapy, which is administered IV. And then we have the mTOR inhibitors. So here's just a list of some of the common therapies that we're using and categorized into which class they fall into. So the VEGF TKIs that we use are drugs like sorafenib, sunitinib, pazopanib, axitinib, lenvatinib, and cabozantinib. The immunotherapies are nivolumab, pembrolizumab, ipilimumab, and avelumab. And the two mTOR inhibitors are everolimus and temsirolimus. So what I'm going to do is talk about some of the toxicities within each of these three classes, and we'll start with the VEGF TKIs. So I think in order to really understand some of the toxicities here, it's important to have just a basic idea of how these VEGF TKIs work. So these drugs basically inhibit blood vessel development that is feeding the kidney cancer tumor, and that's known as angiogenesis. And so all of these therapies basically inhibit this VEGF receptor. They can also inhibit other receptors like you see here, c-MET or FGFR, as well as a whole host of other receptors that also contribute to blood vessel growth and proliferation. So as a result of that, these VEGF TKIs can cause a number of toxicities, and I'm first going to just go through broadly what some of those are and try to categorize them, and then we'll delve a little bit more deeply into some of them. So skin toxicity can be a big one. We'll talk a little bit more about hand-foot syndrome and go into detail there. There can be changes in hair or skin color, particularly whitening of the hair or depigmentation of the skin. In terms of oral toxicity, there can be a lot of inflammation of the mucous membranes of the mouth, known as mucositis or stomatitis. There can be taste changes and dry mouth as well. There can be a lot of GI toxicity manifesting as diarrhea and nausea. And then cardiovascular toxicity is a big one, based on what I just told you about these drugs inhibiting that process of angiogenesis. So patients can develop high blood pressure, heart failure, even heart attacks and blood clots. And then there's a whole host of other toxicities as well, which don't really neatly fall into one category, but they're things like delayed wound healing, which is why we recommend that these drugs always get held before a procedure and after a procedure. There can be protein spillage in the urine, there can be bleeding, low blood counts, thyroid abnormalities, which is why we're always checking thyroid function in the clinic, weight loss, decreased appetite, and fatigue. So to talk a little bit first about hand-foot syndrome. So the way this typically manifests is by these localized tender lesions, which often appear as blisters in areas of trauma or friction. So the hands and feet are really the prime targets for this. Patients can also complain of a lot of tingling or burning. There can also be decreased tolerance to really hot temperatures, like hot water. And patients can develop a lot of calluses. You see an example of that up here. Hand-foot syndrome, it can occur at any time, but typically we're seeing it within the first 2 to 4 weeks of starting therapy. And it's variable how frequent this is based on which TKI you're on. But for example, with cabozantinib, which is one of the more common ones we're using, it can occur in up to 40% of patients. So prevention is really key when thinking about hand-foot syndrome and how to best manage it. I kind of like this acronym here, POPs, as a way to think about prevention. So the first thing is trying to pedicure the feet, and what I mean by that is really trying to remove calluses before treatment even starts. The O here stands for ointment, so it's important to use a lot of moisturizers and lotions multiple times a day. Really thick ointments like this urea cream are often helpful, but there are plenty of others. Eucerin cream or Nivea cream can be especially helpful. It's also useful sometimes to use these patches on areas of the feet that might be particularly prone or might have calluses to begin with. These moleskin patches can be found really at any drugstore and I think are quite useful. And then finally, it's really important to try to wear shoes that have soft soles and are not overly constrictive, because you don't want to increase pressure and friction on these areas. Similarly, thick socks can be helpful, and for the hands, thick gloves. And then finally, although it doesn't really fit into the acronym, again, it's important to try to avoid exposure to things like hot water, because that can be a particular irritant with hand-foot syndrome. So once hand-foot syndrome develops, there's a couple of additional strategies that we have for managing it. So if patients just have mild symptoms that aren't necessarily affecting their day-to-day activities, we often just recommend liberal use of moisturizers and trying to further reduce pressure to the affected areas. But when more moderate symptoms develop that may start to affect daily activities, we have a couple of strategies. Sometimes we'll use topical steroids. For discomfort, we'll often use topical lidocaine. Another option is topical DMSO cream, or even an oral therapy, gabapentin, can be helpful as well. Sometimes when symptoms are particularly bad, we do need to modify the dose of the TKI therapy, and that tends to be particularly effective here when we've exhausted some of these other options. For more severe symptoms, so when symptoms start to manifest as peeling, blistering, or just really severe pain that's limiting you from doing really any daily activities, that's when we really need to discontinue treatment, often for at least a week, but really until symptoms start improving. And at that point, we can then resume treatment, typically at a dose reduction, to avoid these symptoms from recurring. So moving on to oral toxicity with the TKIs. So I mentioned this is mucositis or stomatitis. Often occurs within a month after starting treatment. And you can see here that patients can manifest these sort of ulcers in the tongue or along the gum line or on the inside of the cheek. But they can also have just increased sensitivity even without any visible ulcers present. So that's important to note. This tends to be most common with drugs like sunitinib and cabozantinib, where up to 50% of our patients can have this happen, and is less common with drugs like pazopanib and axitinib. This is also a pretty common toxicity with the mTOR inhibitors. And with the mTOR inhibitors, this sort of mucositis can actually occur quite quickly after starting the drug. And it's very clearly a dose-effect relationship, it seems, with the mTOR inhibitors, so we often need to dose modify. In terms of managing these oral toxicities, mouthwashes can be particularly helpful. So in Dr. Haas's clinic, we'll often give a dexamethasone swish and spit rinse for patients to use. It's really important, and I highlight here, not to swallow this because it can actually impair absorption of the therapy that you're on. So it's important to remember to spit that one out. There are other strategies, other topical analgesics that come in a mouthwash form, something called Magic Mouthwash, which is a combination of lidocaine, Benadryl, and Maalox. There's viscous lidocaine and benzocaine. And then just in general, I think it's important to emphasize the importance of oral hygiene, as well as trying to avoid agents that are particular irritants, so avoiding spicy food, avoiding things with alcohol, hydrogen peroxide, or iodine. And then finally, as I mentioned, sometimes we do need to interrupt the dose or modify the dose to deal with this toxicity. So high blood pressure is another very common side effect with the TKIs. Up to 80% of our patients develop high blood pressure. And this can be either de novo high blood pressure in someone who's never had high blood pressure before, or it can just be a worsening of pre-existing hypertension. And high blood pressure can actually develop even, within hours to days of starting on these therapies. And it's particularly important because, if patients have a really rapid and acute rise in their blood pressure, they can actually have pretty serious complications from that. So things like stroke, heart attack, kidney injury. And so for that reason, we often recommend that all of our patients have a home blood pressure monitor and are checking their blood pressure on a daily basis and logging it. If patients have a blood pressure that rises above 140/90 on a consistent basis, then we do start those patients on blood pressure medication. One of the rare but very significant complications of high blood pressure and being on these TKI therapies is something called posterior leukoencephalopathy. And basically this manifests with sort of an insidious onset of headache, confusion, visual changes, sometimes even seizures. And when we do a scan of the brain, we see these areas of, these white areas, which are areas of increased edema. And so this is how this phenomenon of posterior leukoencephalopathy can present, and it's really important that if a patient ever were to manifest these symptoms and be on these TKIs, to contact your primary oncology team immediately, because this is something that requires emergency management in the hospital to get control of. But not all hypertension is bad. So hypertension is actually a predictive biomarker in kidney cancer. This was a study that was published in 2011 and looked at patients who were on sunitinib, and this is a curve of overall survival. This top line here represents the patients who developed hypertension on sunitinib, and this bottom line is those who did not develop hypertension. So you can see these curves have a pretty wide separation between them. And if you look up here, the median overall survival for patients who developed hypertension on sunitinib was 31 months compared to only 7 months for patients who did not develop high blood pressure. So in this way, hypertension does actually predict for a good response on these drugs. And so we do like to see some bump in our patients' blood pressure when we put them on these TKIs. It's just a matter of managing it and making sure that that blood pressure doesn't get too high such that we're not running into these other complications that I mentioned. So just briefly in terms of some of the other toxicities that we can find with the TKIs. So fatigue is a big one. There are a couple of strategies for dealing with this, although none of these, really completely modify the fatigue. But things like light exercise and short naps can be helpful. Dose modification is another strategy, including using nighttime dosing. With some of the medications that are given once a day, we can dose them at night, and sometimes that can help with issues like fatigue. Diarrhea is another common side effect that I mentioned. Imodium is particularly helpful here, and we usually recommend patients take 4 milligrams at the start of symptoms and then take 2 milligrams after every loose stool. Creon is a pancreatic enzyme that can also be helpful if Imodium is insufficient. In terms of taste changes and poor appetite, so this can be a little bit tricky in terms of improving. We really don't want our patients losing too much weight when they're on these therapies, so we try a lot of different strategies here. Nutritional supplements can be helpful, things like Boost or Ensure, trying to eat frequent, small, high-calorie meals during the day to keep weight up. If those things are insufficient, though, there are some oral therapies that we can use. Mirtazapine is an oral drug that works to stimulate appetite. It also helps with insomnia. And then we have Marinol, which is a synthetic THC derivative. And then finally, in terms of nausea, this isn't, the most common side effect with the TKIs, but it can happen. And when it does, we often recommend Zofran and Compazine, and often have our patients alternate those drugs to get maximal relief. So moving on to the immunotherapies. So you've heard a little bit about the immunotherapies over the course of the day, but just to review, The way immune checkpoint blockers work is basically by stimulating the body's immune system to attack the cancer. And I really like this picture here. It shows a T cell, one of the white blood cells, attacking a tumor cell. But what can happen here, and in terms of the toxicities, is that if the immune system becomes overactive and not only attacks a patient's cancer, it can also start attacking normal healthy tissues and normal healthy cells, and that's how some of the side effects from immunotherapy happen. Here's a schematic of what some of those side effects can be. Basically, the side effects are all the result of excessive inflammation in various different organs. So I've circled here some of the more common ones. So there can be abnormalities in thyroid function. So again, this is a situation where we're commonly checking thyroid function in the clinic. There can be GI toxicity. So if there's inflammation of the colon, patients can develop colitis, or if there's inflammation in the liver, they can develop hepatitis. There can be rash of the skin. And then some of the other common side effects here would be things like pneumonitis, which is inflammation of the lungs. And fatigue is also another side effect. It's not necessarily directly an immune-mediated side effect, but is something that we sometimes observe with our patients. Importantly, all of these toxicities are on the whole relatively uncommon, but when they do happen, they can be severe and they can be life-threatening. Oftentimes they are relatively time-limited and reversible with use of high doses of steroids. So this shows kind of what the risk of toxicity is comparing combinations of these drugs to monotherapy. So you can see here that for patients who get the combination of IPI and Nivo, the risk of toxicity is much higher than if they just got Nivo alone or pembrolizumab alone. In fact, in the phase 3 study of IPI and Nivo, the rate of severe side effects, grade 3 or 4, was a little over 40%, with up to 20% of patients needing to discontinue this combination of IPI-Nivo. Whereas if you just look at single-agent therapy with Nivo or Pembro, the rate of those severe side effects is probably 20% or less, and the rate of needing to discontinue those drugs was about 8%. So much lower with the single-agent therapy. So rash is one of the more common toxicities with immunotherapy, and rash can be pretty mild, as you see up here in these two panels, or it can be much more severe, as you see down here. Typically, the way we're managing mild symptoms is by using topical steroids, or if itch is a particularly bad symptom, we can use oral antihistamines. But really severe rashes, like the ones I'm showing you down here, do often require oral steroids and holding therapy. So colitis, so this is inflammation of the colon. This typically manifests by diarrhea, abdominal pain and cramping, and sometimes even blood or mucus in the stool. So this here is a picture of a normal colon on a colonoscopy, and this is a picture of a very inflamed colon after immunotherapy. So it's really important here to immediately report any changes in bowel movements to your primary oncology team. And the way we tend to manage colitis, the first step is really just making sure that there's no other contributing factor like an infection going on. Once we've decided that there's not and that this is likely due to immunotherapy, if patients have mild symptoms, we can often get away with just fluids, maybe some Imodium and a bland diet. For more moderate symptoms, though, we often do need to hold therapy and consider starting steroids. And for really severe symptoms, sometimes patients even need to be admitted to the hospital for IV steroids or other immunosuppressive medication. So moving on to pneumonitis, so this is inflammation of the lungs. So over here, this is a picture of a patient with normal lungs before starting on treatment. And this is after receiving IPI-Nivo. So these white patchy areas are areas of increased inflammation. And so the symptoms that a patient would typically have here are things like cough, shortness of breath, or low oxygen on their vital signs. This is something that can also happen commonly with the mTOR inhibitors, so it's not just immunotherapy that can do this. And the way we typically manage this is if a patient is asymptomatic, we can often get away with just close observation or maybe just holding a dose or two of the immunotherapy. So this would be the case if all we saw were these changes on a CT scan, but a patient was otherwise feeling well. Once a patient starts to have symptoms, though, those things like cough or shortness of breath, we do need to hold treatment and often start steroids. So lastly, I'll just touch on the mTOR inhibitors. So here's a list of some of the toxicities that the mTOR inhibitors can cause. A lot of these have some overlap, particularly with the VEGF TKIs. So there can be fatigue, there can be mucositis, low blood counts, there can be GI toxicity like nausea or diarrhea, there can be swelling, issues with wound healing, inflammation of the lungs, which I just showed, as well as two kind of unique side effects, those being elevated blood sugar and elevated cholesterol. So in terms of elevated blood sugar and cholesterol, this can actually affect quite a few patients on these therapies. And it's for that reason that we really need to be cognizant about checking patients' baseline lipid profiles and baseline glucose in the clinic before starting on these therapies, and really closely monitoring those things over the course of treatment. Oftentimes, if the cholesterol gets too high or the glucose gets too high, we do need to start patients on additional medication to manage that. So in summary, treatment with the VEGF TKIs, immune checkpoint blockers, and the mTOR inhibitors really requires very close monitoring for the development of these toxicities. The VEGF TKIs and the mTOR inhibitors, I think, can really produce a wide range of side effects that warrant aggressive supportive care and sometimes dose interruptions or treatment holidays to manage. The immune checkpoint blockade can really cause some unique immune-related side effects, which are often steroid responsive, but in rare cases can be life-threatening. And I think really the most important thing out of all of this is to really make sure that you contact your primary oncology team with any new symptoms, so we can make sure that you're staying safe on these drugs and really preserving quality of life. Thank you.